Perfect. Well, yeah, lovely to see you, Carys. I'm glad we've finally been able to make it work.
Yes, absolutely. Really nice to see you too. So we wanted to talk today, didn't we, about HRT doses. So before we start, how has your week been? We know
Um,
about your hand.
yes, my week has gone really well, actually. So yes, my wrist, which they thought might be broken, I went back to the fracture clinic, and all looks okay, which is great news. So I can take my splint off, which is fantastic news, and hopefully all will be well. So that's brilliant news. What about you? What have you been up to?
Really good. Yeah, I've had a lovely weekend away with my old girlfriends who we've known each other now for 32 years. So it's such a long time. So really, really nice. We sat and did a lot of chatting, cooking some delicious food, a little bit of shopping, but mostly just chatting. So really lovely. Good
Sounds
for the
sounds
soul.
fantastic. Yes. And we're going to talk today, won't we, about HRT doses
Yes.
and things that we need to think about in relation to that, and the things that people listening or watching might be wanting or needing to know when it comes to doses, because there's so much information and there's differing perspectives as well. The guidance has changed in the last couple of years. So it can be quite confusing, can't it? And there's a lot to think about in relation to doses and how we might think about doses. So yeah, where should we start?
Gosh, it's so difficult. I think what we have to do is we need to divide it into the ladies with premature ovarian insufficiency, don't we? Because those ladies require a different approach. And then we need to think about the ladies in between 40 and 45 who have menopause and then the ladies who have menopause above the age of 45, which we would deem to be in the average age range, 45 and above, wouldn't we, to
Mhm.
55 or average
Yeah.
51. So if we start with with people who have menopause under the age of 40, and then we won't not have spoken about that. So
Mm.
there's new guidance that's come out now, hasn't there?
Mm.
The ESHRA guidance showing that people who have menopause or premature ovarian insufficiency, where the ovaries are not functioning as they used to be, um, under the age of 40, that when that it's really important for those people to have hormone replacement therapy unless there is a reason that they shouldn't, a contraindication. And the dose that we should be giving should be approximately 100 micrograms stroke 4 pumps of the gel, 100 microgram patch strip, 4 pumps of the gel or equivalent. So that would, in essence, fall into the high dose estrogen, wouldn't it? Advice. So we would also be balancing the dose with estrogen dose with progesterone or progestogen dose, if that woman requires progesterone. So that's really important in order to help with symptoms and also protect future health. And and then we need to consider those who have menopause between 40 and 45. And I think we need a lot more research in this age group, don't we?
Mm.
Because there is an argument that actually those people who have menopause between the ages of 40 and 45 could be included in the group that have menopause under the age of 40. But it isn't clear that that's the case yet. So I think we need to be a really individualized approach needs to happen for people who have their menopause, which is the year after their last menstrual period, between the ages of 40 and 45. And then we're looking at people who have menopause after the age of 45. And though with that, the HRT then is given to help reduce symptoms, isn't it? And we know it has benefits potentially if we start it early in menopause, for reduction in cardiovascular disease and protection of bones. And the dose then can be adjusted according to the symptoms. And then you've got the ladies or people in perimenopause, haven't you, whose hormones are fluctuating up and down. And that can happen at any time. So we need to think about what dose could be given if we're giving HRT as an option for treatment there as well. Would you add anything there?
Um, I think probably just would be wanting to think as well about women who've had surgical menopause.
Yeah.
So these can be at any of those time points, can't they? But particularly the younger women who've had a surgical menopause, which is where they've had both their ovaries removed surgically for usually for medical reasons. Um, those women often need some of the higher doses of estrogen, don't they?
Yeah.
And I suppose the question around progesterone can be, different depending on their individual circumstances. But often these women need higher doses of estrogen, don't they? Because they've gone into menopause. Often, if they're having the operation at a relatively young age, they've gone into menopause very quickly and suddenly, haven't they? So they don't
Hmm.
necessarily have that gradual transition. But yes, that's another consideration that we often need to bear in mind, and can sometimes be neglected from the conversations, can't they, around
Yeah.
menopause and dosing. And I suppose in perimenopause, I suppose the other thing when it comes to dosing is I often think about how how am I treating this woman? How are we wanting to manage this woman's symptoms? And obviously it's so individual, but for some women, particularly the younger women in perimenopause who are navigating significant hormonal sensitivity, so severe PMS and PMDD, sometimes these women benefit from using an approach where we can sort of stop the cycle and stop those fluctuations, can't they?
Yeah.
Don't so that we're avoiding the sensitivity that comes with those fluctuations. And to do that, we might be using one of the newer contraceptive pills, or we might be using a higher dose of estrogen, like a higher dose
Exactly.
patch, might we?
Yeah. Hmm.
Um, which is a very different approach to perhaps just using some additional hormones to suit symptoms. So using
Yeah.
progesterone, which obviously often declines first in perimenopause, doesn't it? With a little
Hmm.
bit of estrogen just to sort of
Yeah.
just boost things up a little bit. So I suppose it depends on that conversation that we have with patients as to, what symptoms are affecting them most, what actually might they benefit from replacing, what's the likely to be the best treatment approach in this scenario. So it does, like you say, it needs to be individualized, doesn't it? And we need to have information around that woman's symptoms, her life, her medical history, her previous hormone history to help us make those decisions. Um, and I suppose the other thing that we, people often ask us, about, what dose should I start on? And I know there's different ways of doing that, but how would you normally start someone on HRT, Carys?
Again, that's so individual. So in perimenopause, I tend to be, and in women with migraine, so I tend to be very gentle with my introduction of the estrogen. So it's super slow in order to help introduce until the symptoms are controlled. Again, with surgical menopause and premature ovarian insufficiency, it's different. But if I'm introducing estrogen to an older woman who has been without it for a while, I go very gently. Otherwise, I find that those particular women tend to get side effects. So the side effects are the breast tenderness, the headaches, the nausea, the leg cramps, a little bit of bleeding, which often settle over a few weeks. But actually, it's often much nicer for them to go in gently. And usually, otherwise, I would start at a sort of low dose to standard dose, and then I would review after 3 months or so to let the body get used to the new normal. And everybody's so different, aren't they, with how what dose they absorb. So through the skin, we may absorb really well with a gel and not so much with a patch, or vice versa, or with the spray might be really good. So the individual absorption through the skin can vary according to temperature, ethnicity, to hydration, time of day. There are lots of things, aren't there? Or an oral tablet. And then I think that's probably the things that I would consider. And then, if necessary, after 3 months, if symptoms, particularly the vasomotor symptoms, are not controlled, I would be increasing the dose. But also, really importantly, I think when we increase the dose or we need to make a dose adjustment, we need to constantly be thinking, is it something else? Is there another medical condition that could be causing the lack of response here? So often, as we know in perimenopause, it's very unhelpful to take blood tests to check estrogen levels because estrogen's coming from two sources, the HRT and the ovary, potentially. So it can be sometimes helpful on an individual basis, but it's not generally helpful to manage doses. More symptoms, really, I think, are helpful. So I think when you're increasing up, and then you get the difficult decision of when you go on to high dose, you've then got to potentially increase what, but you have got to now increase the dose of the progestogen or progesterone to match that. So, and then you have the thing of, well, what happens if you don't get better on these doses? So then we've got to consider, is it the absorption? Is it that more HRT is required? So we really do have to give that consideration. What do you think?
Yes, there's so much to think about, isn't there? Some women do need higher than licensed
Yeah.
doses, don't they, to navigate their symptoms, particularly some of the younger women, so POI and particularly surgical menopause, need to use higher than licensed doses on an individualized basis. But that's something that would always be discussed at length, and we'd always be thinking about, like you say, other causes of their symptoms. Is there a reason that they're not getting better? Is there a lifestyle factor that's actually contributing to the way the hormones are being metabolized, and is somebody perhaps they're on a decent dose, they're absorbing it, but their body isn't able to metabolize it as effectively as it could do because of gut health, because of
Yeah.
stress,
Yeah.
and all these factors, and I also see sometimes, particularly as we're increasing doses, if somebody has histamine intolerance, it can seem like symptoms are worsening, but actually it's because of the histamine, and the more we give, the more those symptoms get worse. But actually, it's not more HRT that's needed. It's looking at those other factors. So there's so much to think about, isn't there? And like you say, it's really, really important. I think the really important thing is that doses of estrogen and progesterone, where appropriate, are balanced, and that's done accordingly, partly for symptoms, but predominantly for keeping the lining of the womb nice and thin, so that we can avoid any thickening of the lining of the womb, bleeding problems, and ultimately, we want to avoid any thickening that potentially could turn into precancerous or cancerous changes of the womb, don't we? When we're giving estrogen is something that's really important to consider.
Yeah.
And you mentioned blood tests, which we both know are very variable in perimenopause and aren't particularly helpful. But I get lots of questions, particularly if I'm doing, women's annual reviews of their HRT, women asking, can I have a blood test to see what my levels are, to see if things are still the same, if things have changed. And I don't know about you, but that's tricky to interpret those results, aren't they? You were
Yeah.
at the BMS conference last year, weren't you, where there was the discussion and the presentation around actually how, if we do somebody's bloods over a 24-hour period, someone who's stable on their HRT, someone who's post-menopause, they can still have varying and wildly different levels of estrogen in that 24-hour period, didn't they? Which I thought was really interesting.
Really interesting how we absorb it and how it varies over the day and how different products vary. And actually, we're only really just looking at our estradiol that's in the blood. But what about what's in the cells? What about the other types? Of or potentially, if we're looking at aromatization in the other target tissues, does that matter? There's lots of questions, aren't there, about it. So. And then you come to the question of, well, how much should we have in order to protect bones?
Mm.
And sometimes people want to increase the dose. in order to achieve a blood test level despite feeling well. So it is a really difficult, it's an individual conversation, isn't it? Sometimes blood tests really are very helpful because they are helpful. For example, I had a young lady with a surgical menopause who was actually on 250 micrograms of patch. And she was very symptomatic with lots of vasomotor symptoms, so hot sweats and night sweats, and lots of mood changes and other symptoms. And what we did was change her onto 2 pumps of gel, and actually she absorbed beautifully, and her symptoms were much better. But the blood test that we did showed that she had very little estrogen going in through the patch. So it's always, I suppose, a consideration to think if somebody's not absorbing the symptoms are not controlled on on a dose, a high dose, is another product actually going to be a lot better? And there are some out there that have been through every product and actually absorption is very limited. So the minority of women may really struggle with different products to absorb, and we have to go in different sort of regimes with them. But most people, I think if you're increasing and you're really not getting symptomatic relief, it is always an advantage to think, right, let's think, what else could be causing this? What in your lifestyle could be contributing to your symptoms? And shall we try a different product for better absorption? And shall we also make sure that you're using it correctly? Because the use of the product, so the gel needs to be rubbed onto the arm or the inner thigh, avoiding breast and genitals, left to dry for 5 minutes. Wash your hands. Don't get dressed until it's dry, and don't shower or apply other creams, or have prolonged contact with others, including pets, for 2 hours afterwards, just to let it absorb in. And again, the patch must be stuck correctly and replaced onto clean, dry skin as is directed for that product, usually twice a week. If it's dangling off by a little thread, it's not going to be absorbed well. And I have seen somebody came in with theirs with a little black thread, the whole lot of it dangling off. And we were laughing about the fact, there cannot be any hormone absorption going in there. So it's really important to make sure it's stuck well to the skin. If you're finding it on your husband or in the bed, or it comes off every night, or you go swimming and it's off, it's just not right. So we've got to find another product. And again, there are two types of gel, aren't there? Sometimes the Sandrina is absorbed better than the Estrogel. And then Lenzetto, it's really important that it's sprayed correctly, left to dry for the minute, and that you again leave it to dry in and you're not putting other products on top. And the oral tablet, again, taking it correctly. So if you are and it's so important to be honest, isn't it, about these? We are only human. We're all human. So I speak to lots of people who just forget. They just simply forget to take it, or they forget to take it off, or they forget to replace it. And if that's happening, then it's just really important to take a product that's easy. That's probably going to be one of my highest recommendations, is take the thing that is going to be easy for you to remember. If you're really worried every night because you're terrified you're going to forget your progesterone, and you're on your Nutrigestan, and you're worried, then and you do keep forgetting it, and then you're getting irregular bleeding, then there are other ways of taking it, aren't there? So the little Marinic oil, or through a patch, or a different tablet. So there are things that you can do to make life easy, and so taking it consistently with good compliance is very, very important. And particularly with the Nutrigestan, sometimes I find this, I'm sure you're the same, that it's really important to take it exactly as it has been prescribed, despite bleeding. So not that you're waiting for your bleed to come, or so if you've been told to take it for days 14 to 28 of your 28-day estrogen cycle, that means you still do that even if whenever your bleed starts. You just tell us when your bleed starts, but you still take, for the first 2 weeks of the cycle, or for every day you take estrogen, and for the first 2 weeks you don't take Nutrigestan, and then for the second 2 weeks you do, and then you repeat that 2 weeks on, 2 weeks off, 2 weeks on, 2 weeks off, no matter what's happening with your bleeding. Because I think if you don't get the doses right of both, then you can start to have symptoms, can't you? And you start to get what would be perceived as side effects, and then you make dose adjustments which possibly aren't necessary. What do you think?
Yeah, completely. I think that's one of the, when I'm talking to women who are not getting on with their HRT, or they're feeling like their symptoms are coming back, not always, of course, but it's not uncommon that actually the progesterone isn't being taken in the way that it's prescribed, and that means that the balance of estrogen and progesterone through the cycle isn't quite correct. And then, you know, the application of estrogen is a bit of a minefield, really, isn't it? I've come across women who are doing, when they're saying that they're putting on 3 pumps of gel, they're just doing the tiniest little squidge from the estrogel,
Yeah,
not putting
yeah.
it down fully.
Focus. Yeah.
Or Lenzetto, the important thing is it's popped in the same place each day, isn't it? Because it builds that reservoir. So it is really important just checking that we're using it according to the instructions.
And the other thing with Lenzetto, just while we're talking about that, is that there's the three prime
Um,
sprays, and then there are only 56 sprays left. So even if you feel you have more in the carton, there isn't more.
yeah,
It's just
yeah,
it's just to be, so they get a little Sharpie right on the outside of the thing when you're supposed to. So my light's just gone off there, probably plunged into darkness. So when you're supposed to be changing your carton, and then you know that you've only got that certain amount of time that you use it for, and you know when the last date is going to be.
yes, and quite
Um,
helpfully in some of the boxes, it has a little card where you can mark off the sprays on it,
yeah,
which is really useful to do as well.
yeah.
And I suppose the other thing when we're talking about doses is, we've mentioned sort of individualized circumstances where people are taking higher doses, which is absolutely the right thing for them in the circumstance. But, what does the evidence say around higher doses generally?
I
Um,
think we don't know, do we, what the
no.
effect of that is, and that's a great concern. I think it's a great concern with lots of us, isn't it, as health professionals, about the doses that some people are presenting to our clinics taking. We don't know the effect of that. And we don't really understand. So sometimes people are coming in with blood levels which are really very high as well. And we don't know the effect of using the higher dose of progesterone or progestogen on the breast. We have very little data when we're looking at use of the higher doses of estrogen. So what we may then help women to do. So if that is happening to you and you are on high doses or higher than the licensed dose, and you feel that actually you would like some support with that, we can help you wean down. It's something which can be done safely and slowly, with guidance, so that we can talk to you about how you're feeling, make sure there's not another diagnosis, and then help you with reduction of your dose if that's the right thing for you to do. For some people, very young women who need protection for bones and who really aren't absorbing well, they may need, it's a different matter, isn't it?
Mm.
But there are some people who have been advised to increase it or have themselves increased it under watching something that maybe wasn't medical advice. And if that's the case, then we can help with helping you assess what's right for you, and also whether this is the right product or whether a different one might suit better. And sometimes there are certainly these individual women that need higher doses, without a shadow of a doubt. We all have them in all clinics, don't we? There's no doubt about that. But there are not many, and most people, I have, in my own personal practice, have found that when sometimes women just don't feel well on the higher doses, and actually when they do change to a product they are absorbing well and take it within licensed doses, many, but not all, but many do find that they have better symptom control on that. So it really is a case of sitting down and going, right, what is it that you're doing? How are you taking it? How often are you taking it? Because people will do all sorts of things, won't they? Sometimes people get up in the night and rub a bit of estrogel on to help them sleep, so this isn't the way of using it. But we do different things. When we're desperate, we do things, don't we? We just do
Mm.
things to feel better. And actually, we need to be really honest about that, and to approach it in a positive, supportive, constructive way, so that we can help think, right, where are you now? What do we know and what don't we know about what you're doing? What risks are there potentially? And how can we help you to get to a different place from this, if that's what you need to do. Bearing in mind that you're right, so we will be using high doses of estrogen in ladies with POI and also in people with PMS, and potentially to suppress the ovarian cycle so that we can help to stabilize the mood. That is not being, those doses of estrogen with PMS are not being done to help the symptoms necessarily, are they? They are being done to help. Well, they are being done to help the symptoms, but in a byproduct of stopping this, suppressing the ovarian function in order to try and stop ovulation, which will then stop production, stop that natural fluctuation of hormones, which can cause lots and lots of really distressing symptoms for people who suffer from PMS and PMDD. And this is the guidance we're talking about, is licensed and is recommended by the Royal College of Obs and Gynae in their PMS guidance. So there are lots of different ways of using HRT. There are lots of different requirements to consider when you are assessing somebody individually about the age, about the absorption, about that. But there are also people who may want to be in a different place. They're worried about how much they are taking, and actually they would like to reduce the dose and maybe not know how that is, or they don't know whether they balance things properly. So I think there's always help out there. And if there is a concern, we can help you. You can make an appointment with Rachael or with or with me at Row Enna Health, and we can help you to understand exactly what's right for you and your body, because it's very difficult to foresee what questions might come, and sometimes we can hear things and think, well, that's actually really easy to sort out, but it seems like it's a big problem. But we can, and lots of doctors and clinics can help do the same thing, to help address these doses or any concerns that you have with side effects.
Yeah, I think in summary, I think essentially the takeaways from this are that there's everything really needs to be individualized. There's no, we've
Yeah.
got guidance, but there's different guidance that applies to different populations, different people, different scenarios, different ages. So it's really, really important that you can speak to somebody who understands the evidence, understands the guidance and the research that we have, and is able to listen to what's going on for you, your individual symptoms, your worries, your concerns, and can help you understand what the data and the guidance and best practice shows, and then put it together in a way that works for you, with a plan that works for you moving forward. And I think that's the essence of this, that there's no necessarily right or wrongs. Everybody will have their own needs, their own requirements, and it's about understanding how that fits with what we know, so that you can come up with a treatment plan that works for you and your individual needs. So I think that's the takeaway. So I think one of the worries that I have lots, I'm sure you hear this as well, but people say, oh, I'm on this dose, but my friend is on this dose. I think I'm on the wrong dose, but we can't
Mhm.
compare a lot of the time, can
Biologies.
we? It's
No.
so different. So having an individualized approach, which is holistic and takes in everything to account, is really, really important. If you do have any worries, don't adjust your dose yourself unless you've
Good
had
point.
guidance to do that. Speak to a professional, speak to your GP or a menopause specialist like ourselves. Yeah, I think we've covered quite a lot, haven't we, Carys?
We have. I think that was a really constructive, that was a great conversation. I think it's really important. It's nice to hear, it's nice, I think, for people to hear us talking about how we might approach things, but also how everything's so different. And it really does make it, I think, clear with the individual approach thing, because there isn't just one size fits all. If there was, it'd be so simple, wouldn't it? We'd all have our heads around it. We'd know exactly what we were doing. We'd know what dose was needed for everybody. But thankfully, the world isn't like that. We all are individual. We have to take an individual approach, which makes things a lot more interesting, but can have its challenges.
Definitely, yes. So yeah, no, thank you so much, Carys. It's been great chatting about this.
Pleasure. Same to you.
So yes, we'll have to sort out a topic for our
Yes.
next conversation. So if anyone's got anything that they'd like us to cover, do just drop us a note in the comments, and we can look at covering that on one of our next ones. So
Yes.
yeah, thank you very much. I'll just stop the recording now.